Hello friends. So today I'll be talking on this 38th COVID update, which is the second wave in COVID. So as you all know, second wave of COVID is sweeping our country, and Delhi is seeing the huge scourge of this disease with no ICU beds available, and the disease is quite rampantly present in Gujarat as I speak now. So from Karnataka, obviously we are all worried that the second wave would affect our state as well. I think the key aspect of second wave is, at least what I hear from Delhi and Gujarat, is there are no ICU beds at this point of time. So obviously we need to put in all measures in every state, at least in our state, in Karnataka, to see that whole capacity building happens and we are not in the same situation as we were with lack of ICU beds. So obviously we need to look into the science as to what other countries have learned about the second wave and what are all the capacity building measures that we need to incorporate anticipating second wave. So this talk I'm giving on actually 24th November, but I prepared this on Sunday 22nd November. So the way I would look into this is I've picked up two important papers. So the first paper is this one, second wave of COVID, which is determined by immune mechanism. So this immune mechanism which determines as to the patients who get affected during second wave is something very important for all medical professionals to understand and keep in mind. So this is a very good paper. You can read this paper. So I've just tried to simplify it as to what are all the immune mechanisms which determine the second wave. See, when a patient is affected with the COVID, there are two types of immune response the patient mounts. So one is the innate immunity. So this innate immunity is mediated by these variables. Natural killer cells is one of the variable which influences innate immunity, complements interferon and IgA, which is present in saliva and other body fluid. So these are the variables which influence the innate immunity. So what we understand by innate immunity is the virus would not enter into the bloodstream to cause viremia and turbulence as we would see in more sicker patients, and pretty much the virus is cleared at the entry site. So once the virus enters, the local immune mechanisms mediated by this complement or interferon or IgA and the natural killer cells will eliminate the virus. So this is very important for us to understand. The patients who have escaped the wrath of the disease in a mild symptomatic form or who have been asymptomatic. So these are the patients we assume, and this paper has come in a journal called Medical Hypothesis. They have mounted innate immunity and they have been able to successfully eliminate the virus at the portal of entry. So the second type of immune response a patient mounts is something called as adaptive immune response. So what happens is adaptive. So adaptive immune response is something that gets mounted when extensive viremia happens and extensive viral replication happens. So there is a lot of viral replication that happens within the body, and that is when there is a viremia and then there is an adaptive immune response that is mounted. So what are the variables that determine the adaptive immune response? It is mainly determined by these CD8 plus lymphocytes. So these CD8 lymphocytes, they sort of interact with this class 1 major histocompatibility complex antigen. So and they become activated. So they got something called cytotoxic CD8 plus cells. So they basically interact with the MHC antigen and they form cytotoxic CD8 plus cells, and they become something called memory cells which enter the monoclonal pool. So these are the memory T cells which remain in the body and they enter the monoclonal pool, and they are the ones which contribute for long-term immunity that these patients tend to acquire, tend to develop against the COVID. So that is the adaptive immune response. So why this is important is when we talk about reinfection in the patients, so reinfection is very common in patients with innate immunity because it is very short-lived, and these are the patients who do not have memory T cells to identify the virus and mitigate the further invasion or further manifestation of the virus. So the bottom line is when there is no adaptive immune response, which means when there is no activated CD8 plus cells or memory T cells, then they are at a risk of reinfection. So which means to say the class of patients who have developed innate immunity would be more vulnerable. Patients who have good adaptive immune response or who have memory T cells, because when you say adaptive immune response, they have memory T cells, so they are not vulnerable for reinfection. So this is a very important aspect which influences who would develop the reinfection. So they are susceptible for reinfection, and these are the patients who can steadily accumulate in the population over a course of time, and they can continue to get reinfected in a matter of few months, and they can even be a super spreaders because they are the people who are asymptomatic and who can tend to spread the infection. So this is an important immunological reason. Or see, if we talk about what are the factors which determine the second wave, it is the viral factors. If you say viral factors, as of now we understand there is no mutation that has happened and the virulence remains the same. The second aspect is we talk about host factors, and in host factors the immune response of the host is what would determine whether they would be vulnerable for a reinfection or not. So, COVID-19 second wave is an intrinsic feature of viral outbreak. So, when someone asks me, there are a lot of people who ask me whether I predict. I'm not a magician to predict, but the intrinsic feature of viral outbreaks is second wave is common. So, it is bound to happen, and we have witnessed this happening in Europe, and we are witnessing this in India. So, second wave is something that is very intrinsic. So, the first wave, so if you look at the pandemic or what we are witnessing, the first wave where we see an acute rise in number of cases with very sick patients getting admitted, generally you will have patients with more adaptive immune response in that. And the subsequent second wave, it is said predominantly these are the patients with innate immune response because the reinfections would be happening in someone who has escaped the wrath of the disease and who otherwise may have been asymptomatic or mildly symptomatic. And generally, as per the scientific literature, it is said that the second wave, where if we assume that they have more of innate immune response, the case fatality rate should be low. Because the first wave will be predominantly the population with adaptive immune response, where the fatality rate, because they'll have more turbulent course, and that is where they would have mounted adaptive immune response and mortality would be high. So this is as per this particular paper. And as I already mentioned, because there is this innate immune response and this population, and they continue to spread the infection, then this infection enters into a phase of endemicity. So, which means there are certain viruses which I have already mentioned in one of the talk, which exhibit this sort of a typical feature of endemicity. So, one is influenza virus, which tends to produce the endemicity, and then you have respiratory syncytial virus and rhinovirus. And coronavirus also is similar to this, that reinfections are a norm. And the reasons for reinfection is, as I mentioned, someone who has insufficient adaptive immune response, which means predominantly they may have innate immune response, or where their immunity would have waned away, or there is an entity called immune escape, which typically means that it has circumvents the sterilizing capacity of the immunity. So immunity has lost its ability to mitigate the virus, and they are the people who tend to have subsequent infection. So these are the immunological reasons as to why someone becomes vulnerable for reinfection. And in COVID, based on the experience from the previous coronavirus, reinfections are common in 1 year. Unlike your influenza, where reinfection tends to happen in 2 years, corona or COVID, reinfections tend to happen within 1 year. And it is again, as I reiterated, someone who has had a innate immunity, so the viral shredding, the shredding of the virus is more longer, and they have reduced antibody levels also. And that we have seen in our own colleagues and friends who have had a milder infection where they have got the antibody testing, their antibody levels have not been very high. So what it again goes on to say, someone who develops innate immunity and who have been mildly symptomatic, we have not seen a high antibody levels. But in someone who has had a little more turbulent course, they have an adaptive immune response, and these are the patients who tend to have higher antibody levels. So the key determinants of reinfection, which I have mentioned in the past, is 3 I's and S. So immunity. So again, we have understood this, that innate immunity, short-lived immunity, adaptive immune response, long-lived immunity. And all this behavioral interventions. So social distancing, remaining at home, washing the hands, masking, all these are very important determining factors, because as friends you all see, the second wave was did commensurate in Delhi with the festivities that happened and with the seasonal change, with the winter that is setting in. So seasonality also is an important factor that plays a crucial role in the second wave. And behavioral change of the public. So public letting down the guard is an important factor which determines the occurrence of second wave. And this I mentioned interaction with other viral infections during winter season, because winter is the time where other influenza virus or H1N1 and other viral infections are more common, and the cross reaction between these virus has been sort of demonstrated, at least between the rhinovirus and the influenza virus, which offsets the severity of one another. So the co-infections that can tend to happen in the winter season also is a determinant of the severity of the second wave. So I'm just showing the curve of this Karnataka. So right now, if you look at our case fatality rate, so this was in the June where it was very high, and as you see, it is sort of steadily and slowly coming down. So now it is around 1.3 in that round. So we really do not want to see this spike again in the second wave. So that is our whole earnest effort and intent, that we should put multimodal measures to make sure that this second sort of a spike of deaths do not happen. I think from intensive care perspective, that should be our primordial motive. So to that effect, this paper is a very good paper. So I urge all the listeners to go through this little paper, which I sure will throw light on all the measures that any state or any hospital or any region has to adopt to mitigate the second wave, or at least to mitigate the wrath of the second wave. So this is an important position paper. So this is a position paper from the Association of Schools of Public Health in the European region, which is called ASPER. So it's a very important document, and we should give value to the contents of this and adopt it to our own region to mitigate the second wave or the severity of the second wave. So now we need to understand, when people say, many call, the media people call me and ask me whether are we in second wave. So we need to know the definition. What is second wave? So the definition of second wave is there should be a disappearance or near disappearance of the cases. So which means right now in Bangalore we had peaked around 3,000 cases. Today it is come down to less than 1,000. So we still do not know if we can call it as uh, disappearance. So the disappearance or near disappearance, and then there is a sudden spike of the infection which is time bound. So it happens at a particular time and in particular geographical area. So after near disappearance, you would see an exponential increase in the cases during particular time in a particular geographical area, and this particular pattern will have a direct bearing on the behavioral patterns of the virus and the society in general, and the population in general. So I think this definition, if you apply to what has happened in Delhi, I'm sure you would agree with me. There was a behavioral change in the population with more density, more people shopping, festivities, seasonal change. All this has had a bearing on this. So this is the definition that is accepted for the second wave of what do we understand by second wave, and and the recipe. What is the recipe for the perfect storm? Once we remove lockdown, so that becomes one of the recipe, or no herd immunity. So we know for sure right now we are not in a phase where we can say we have developed herd immunity, because herd immunity is when more than 50% of the population is already infected. So we have not achieved that. So when we attain a situation where there is no lockdown, no herd immunity, no effective vaccine, and no effective absolute drugs that can eliminate the virus. So when these situations prevail, so this becomes a recipe for the second storm to prevail. So that is what we need to understand. So what are the measures that this particular position paper suggests? So it is whatever I'm talking is not rocket science. All this we have done already in first wave. We need to re-emphasize on all this. So the measures that is suggested in this paper is, it is all the first wave measures that we put in measures and intensifying and cascading that first wave measures. So we need to re-emphasize and cascade the measures that we have put in first wave is what this paper suggests, which is more active surveillance. So more intensifying the surveillance in any place where there is a possible outbreak, and effective contact tracing. I'm sure Karnataka has done an exceedingly good job in doing contact tracing by doing number of tests, identifying the contacts, tracking them, tracing, tracking, containing, treating. So all these measures which we have done in the first phase has to be intensified in second phase, and there should not be any sort of a complacency in that. And most important is this, all this public behavior. So social distancing, washing hands, wearing mask, cough etiquette, and avoiding crowded places. All these are simple elements which we have been following, which we should continue to follow and not let the guard down to prevent the second wave. So this has been emphasized in this as per position paper. This is an important thing they have emphasized in this as per paper, shielding the vulnerable patients, because we have realized in the first wave the predominant deaths that have happened has happened in elderly patients with comorbidities. So shielding this vulnerable, when we say shielding, we call it as reverse quarantine or protecting them, not allowing them to go to the crowded places and keeping them at home pretty much, and avoiding contact of these vulnerable people with younger people within the home. So all these are the measures that has to be re-emphasized to in the second wave also. And this is very important. I would re-emphasize mass gatherings have sort of definitely seen sudden increase after the first wave, and we have seen the marriages happening more frequently, people going to temples, and we have had few festivals where there have been mass gatherings, and we clearly understand even in the first wave the whole instigatory events were all the mass gatherings, even though when the first wave happened. So we should not do the same mistake of having any of these mass gathering. So I would in fact be going a step forward in putting this sort of a, like how you put a signal boards. I think it is desirable that we put ban on this social gathering by putting these hoardings everywhere, so that people sort of tend to understand and stop doing this gathering. And first wave we did have this shortage initially of PPE. So having this stockpiling of mass PPE so that there is absolutely no shortage when the second wave arises. So as you see, all these measures we have adopted in first wave. So it is to intensify all these measures and keep yourself prepared for the second wave is what this position paper suggests. And planning for a severe flu season, so it is suggested that all the healthcare workers and shielding the vulnerable people, they should get a flu vaccine, because you do not want to have a co-infection with influenza which is complicating the virus. So it is suggested that enhancement of the vaccination program for children and elderly for the flu, and even the healthcare workers should happen. So that is also is emphasized. And this may not be applicable to some of the warmer climatic places in India, but winters are very cold, and cold stress is something that can worsen the manifestation of the infection. So protecting the elderly from exposing to cold and protecting themselves, keeping themselves warm is emphasized in second wave, because second wave is bound to happen in winter even in India. So cold stress is something that needs to be avoided, and focusing on keeping vulnerable people warm and avoiding exposure to cold is something that is emphasized. So this is an interesting thing which I'm sure most hospitals are adopting, the recoiled spring of unmet health needs. What that means is, see, right now in Bangalore or Karnataka, we can say we may be at the nadir of the first wave or somewhere here. So here there is a suggestion that non-COVID backlog. So because in the first wave, none of the elective things happened, and none of the other non-COVID patients were looked into. So there is a suggestion from this as per guidelines that all these other elective cases which were long overdue or other non-COVID conditions should be addressed as a priority, because this is the time we have time and resources where these patients can be taken care of, and we do not want these patients to be burdening during the second wave. So that is what is called as unmet health needs to be met during the waning of this first outbreak. So which means if any elective, if someone is planned for some surgery that could possibly be done during the time when we have not seen the onset of the second wave, and addressing the mental health, because there are a lot of mental conditions which were not addressed during the first wave, during the COVID, and all cardiac intervention, because someone may have been scheduled for angioplasty or CABG or some valve surgery. All these need to be addressed during the phase between the first wave and the anticipated second wave, and any cancer screening that was pending, or any other sort of a medications or a drug administrations or any other vaccination schedules that someone may have missed. So this is something that needs to be intensified during the phase when the first wave COVID is seeing the downturn and we are anticipating the onset of the second wave. So this is the phase where I think at least in Bangalore and in Karnataka, our energy should be put in trying to clear all these backlog cases and addressing all the backlog sort of a procedures or other aspects that patients may have needed. So now there is an increased emphasis on lockdown illnesses, which is physical, mental, and social. So there is a perceived burden because of the first wave. Many of them were sitting at home. So there is a additional burden of patients putting on more weight. So all this is something that needs to be addressed during this phase. And people eating refined food, and alcoholism has significant apparently increased in the West also, because people are staying at home and not working. So these are all the additional burden which should be addressed during this phase and before the second wave. So because all these aspects would compound the second wave, and domestic violence is something that tends to happen, and loneliness and insomnia is something that happens, and the overcrowding. So these are all the social factors which could additionally burden during the second wave, and there is a suggestion that all these aspects also have to be addressed during this particular phase. Okay, so the fifth aspect is impact of health and care staff burnout. So I'm sure the listeners, all of you would agree, there is a healthcare fatigue that is set in because of the first wave. It has put in a tremendous burden on the healthcare workers, and the healthcare staff is sort of going through the healthcare fatigue, and that is something which needs to be addressed, is what this position paper mentions. So healthcare workers feel more lonely, and there is post-traumatic stress disorder that is troubling them, and clearly burnout syndrome is something that has been recognized in healthcare workers during the first wave and at the end of the first wave. Social isolation is something that is happening. Insomnia, many of friends who I know who have had COVID, they have suffered some, cognitive or neuropsychiatric issues, and insomnia has been one of the common sort of a symptom that has troubled them. And feeling of being low and hopelessness is something that is troubling. And depression and anxiety are some of the aspects which are troubling healthcare workers. It could be nurses, it could be doctors or paramedics. So there should be a renewed emphasis on addressing the healthcare, sort of a quality of health for the healthcare personnel. So there is a suggestion that occupational health is something that needs to be addressed. So there should be a occupational health cell that should be set up, and the mental health of the healthcare workers has to be addressed, is something that is emphasized in this position paper. And any of the healthcare workers who are troubled with all this, effective counseling of these people should be happening. So as you see, during the end of the first wave, these are the preparedness that the government should put in place to take care of the quality of the healthcare workers, because that can go unrecognized and that needs to be addressed. So that is what this paper emphasizes, and we all recognize that healthcare is going through the healthcare fatigue, and that needs to be tackled effectively. And economic and social intervention, the loss of job is something that is evident, and that has an adverse effects on the health. And so there is an emphasis as a directive or as a request to the governance to give good, durable, and generous economic and social security nets, which means to say that the marginalized sections of the society have to be taken care of, because they were the ones who took the maximum brunt during the first wave. So there is a direction to the governance that they should provide adequate social and economic safety nets for these marginalized sections of the society. And and there is also suggestion that any gaps in the services, because we realized that in the first wave there was interruption in the delivery of certain services. So these gaps should be rectified. So there should be uninterrupted supply of goods and services during the second wave. And there is a suggestion that there should not be any shortage of food, water, or electricity during the second wave. And there should be uninterrupted supply of the medicines. I'm sure this situation will arise when the vaccine comes. So because there may be certain cross-border issues in delivery of vaccines. So there is a suggestion there should not be any interruption in the movement of the drugs or vaccines between the borders during the second outbreak. So so these are all the organizational issues which this paper emphasizes. And policies by consent understood and supported by the people. So what they mean by this in this is the government should not be the only one who should be making decisions for the community. Rather, it is suggested that community should be involved in certain decision making. So basically there is a talk on empowerment of the community. Basically community should also be led to play a responsible role in mitigating the second wave. And so the capabilities of community is something that has to be recognized, and the assets of the community should be recognized and involve them in curtailing and containing the second wave. So the simple sort of an example I can cite as to how community get involved is certain in each area certain community can be empowered to monitor and police mass gatherings. I think that is a simple thing which I'm sure in a community certain personnel can be empowered and they can monitor each other and make sure that mass gatherings are not happening. And community possibly could be empowered to make sure that the vulnerable sections of the society are shielded. If you see elderly man, possibly they could be requested to be remain at home. So these are simple measures where community can itself participate rather than police or BBMP marshals taking on that responsibility, like how we are seeing in Bangalore. Community itself can monitor each other and help each other and trying to educate each other and become more socially responsible. So this is what is something this paper emphasizes. I'm sure this will work even in our city or in our state. So planning for a second wave, planning for winter. So as I said, the ASFR puts in 4 important domains where we should put our mind. So our whole effort should be to reduce the mortality. So this is even the ASFR, the Association of Schools of Public Health, puts its emphasis on putting all the measures to make sure that we keep the mortality low. And the second important aspect the ASFR emphasizes is shielding the vulnerable individuals. So again, here community can be empowered and this message should go loud and clear that no mass gatherings and the elderly people as much as feasible should be confined to home and not be involved in the sort of a public activity because they are more vulnerable and they would reflect on increasing deaths. And there is a suggestion and emphasis on re-establishing and reinforcing the healthcare services and more so the ICU services in India because ICU beds being short was one amongst the contributing factor, at least in the first wave where deaths significantly increased. So creating adequate ICU beds so that we don't fall short when there is a second wave is something that is emphasized in this European statement also. And the second aspect, which is more important, is to address the socio-economic needs of the patients. So instigating and providing socio-economic sort of a safety net is something that has been emphasized. So in this paper, what they conclude at the end is plan for the worst while hoping for the best. So which means you plan for thinking that the worst will happen. So the whole emphasis in this paper is not to let the guard down and intensifying all the measures that have been put in place in first wave rather than diluting any of it is what is emphasized. So in conclusion, the second wave could manifest in 4 different types. It can be low grade continued infectivity, like what we are seeing every day in Bangalore. We are seeing around 1000 to 1200 cases. In Karnataka, we may be seeing 2000. So that low grade continued infectivity may continue. And the second wave, if we believe in the hypothesis of innate immunity, more younger people may tend to get affected in the second wave is what is referenced in this paper. And second wave may not be like a first wave. We may be seeing more local multiple cluster outbreaks, and extensive surveillance has to be put in place to identify the cases, identify, track, trace, contain, and treat these cases locally, and create local quarantines is what is emphasized. Or the worst is disastrous, uncontrollable second wave can happen. And I would say this disastrous, uncontrollable second wave, I have to be very clear, it is going to be due to the public's behavior. Because the first wave, we have proven that government has put in excellent machinery to curtail the death rate, and the healthcare workers have lived up more than to their expectation to reduce the death rates. But if at all second wave happens, it is only the reflection of community and their irresponsible behavior. And if you don't believe what I am saying, this is the leading Italian intensivist who was at the forefront of the pandemic. He made this statement yesterday on the Facebook. After 9 months of experience of COVID in ICU, I am convinced that the best preparation for a surge is avoiding the surge. The biggest difference is not made by hospitals, it is made by the community. So, which means to say, the second wave, how it happens, and the severity to which it happens is purely reflection of the behavioral pattern of the community and not about anything else. So with that, I would leave the whole community to behave more responsibly, take in all the measures and prevent and avoid the second outbreak. So I think this is what we have witnessed already in Delhi, and it has happened in Gujarat. And at least I urge in Karnataka, people are very responsible and make sure the second wave does not surpass our first wave. So thank you very much. So if you wish to rehear to this lecture, you can visit my website www.drpradeeprangappa.com and rehear to gain clarity. Thank you all.